welcome to the deep dive. Today we are really cracking open a huge topic in health sciences, the world of antibiotics.
It's definitely fundamental.
Yeah, and we're going to focus on the first 5 major classes. So sulfonamides, penicillins, cephalosporins, macrolides, and tetracyclines.
That's right.
Our goal here is to kind of synthesize the mechanisms, the uses, and absolutely the critical clinical and nursing points. Give you those high-yield facts you really need.
Okay, sounds good. But before we even jump into the specific drugs, we need to lay some groundwork. There are basically 3 main ways we use antibiotics clinically.
All right, what's the first one?
First up is empiric therapy. This is where you start treatment right away. It's based on your best clinical judgment, your educated guess about what's likely causing the infection, especially crucial in potentially life-threatening situations.
Okay, makes sense. But there's a really key point here about timing, isn't there? Something the sources really emphasize.
Absolutely critical. If you're going down the empiric route, you must get your samples for culture first. Blood, sputum, urine, whatever's relevant.
Before that first dose goes in.
Precisely, because otherwise you've potentially wiped out the evidence the lab needs. You won't know for sure what you were treating.
Got it. Okay, so that's empiric. What's number 2?
That leads us to definitive therapy. So maybe 48, 72 hours later, those culture and sensitivity results come back. Now you know exactly what bacteria you're fighting and which drugs work best against it.
And then you switch?
Then you tailor the treatment. Ideally, you switch to the most narrow-spectrum drug possible, the one that targets just that specific bug, and importantly, the least toxic option. That's really the core of good antibiotic stewardship.
Right, avoiding the big guns unless absolutely necessary.
Yeah.
And the third use, that's more about prevention, right?
Exactly. Prophylactic therapy. This is giving antibiotics before you expect someone might be exposed to infection.
Like before surgery.
That's the classic example, yeah. Preventing surgical site infections. But here's a crucial implementation detail. For it to work effectively in surgery, the antibiotic has to be given within a pretty specific time frame, usually about 30 minutes before the first cut.
Wow, okay. So that needs careful coordination in the OR.
Very careful planning, yes.
Okay, let's quickly nail down some basic vocab we'll be using. How do we talk about what the drug actually does to the bacteria?
We generally split them into 2 main types: bactericidal and bacteriostatic.
Okay.
Bactericidal means the drug actively kills the bacteria, often by, breaking down their cell wall. Bacteriostatic, on the other hand, just inhibits their growth or reproduction. It stops them multiplying.
So with bacteriostatic drugs, you're kind of relying on the patient's own immune system to do the final cleanup.
That's exactly it. You're giving the immune system a fighting chance by stopping the bacterial army from growing.
All right. Moving on to some general principles, we need to talk about the bacteria themselves. We often hear about gram-positive and gram-negative.
Yeah.
What's the deal with the gram stain?
It's all about the cell wall structure. When we do the gram stain, if the bacteria hold on to the crystal violet stain and look purple, they're gram-positive. They have a thick peptoglycan layer in their cell wall.
And that makes them easier targets.
Generally speaking, yes. That thick wall is something many antibiotics can attack effectively. Now, if they lose the purple stain and pick up the red counter stain, they're gram-negative.
And these are tougher.
Usually, yes. They have a much more complex wall structure. There's a thin peptidoglycan layer, but it's sandwiched between an inner and an outer membrane. That outer membrane acts like an extra barrier, making it harder for many drugs to get in.
Okay, that complexity links directly to probably the biggest challenge in this whole field: resistance.
Oh, absolutely. Antibiotic resistance is a huge global health crisis. Our sources are clear. It's driven primarily by overprescribing antibiotics when they aren't needed.
Like for viruses.
Exactly.
Yeah.
And also by patients not taking the full course of treatment, they start feeling better, they stop taking the pills.
And the tougher bacteria survive and multiply.
Precisely. It selects for resistance.
And a related problem that comes from using antibiotics, even appropriately sometimes, is superinfection, right?
Yes, superinfection. This happens when the antibiotic wipes out not just the bad bacteria, but also the good bacteria, our normal body flora that usually keep things in check.
Creating an opportunity.
Exactly. You create a sort of vacuum and opportunistic pathogens can take over. Classic examples are things like vaginal yeast infections or oral thrush.
And the really serious one.
The big one is Clostridioides difficile, or C. diff. This causes severe, potentially life-threatening antibiotic-associated diarrhea or colitis. Any patient on antibiotics who develops significant watery diarrhea needs testing for C. diff right away. It's a major safety concern.
Good point. Just to clarify terms quickly, when we talk about cleaning surfaces versus skin.
Right. We use disinfectants on non-living things, tables, equipment. They're usually cytal, meaning they kill microbes. Antiseptics are used on living tissue, like skin before an injection. They're typically static, inhibiting growth rather than outright killing to minimize tissue damage. Different goals.
Okay. Before we dive into the actual drug classes, we absolutely have to touch on host factors.
Yeah.
Why the same drug can hit two people so differently. Age seems like a big one.
Huge. Think about the extremes. In infants and young children, certain antibiotics are a no-go. We absolutely avoid tetracyclines, quinolones, and sulfonamides because they can interfere with developing bones and teeth.
Right, permanent staining with tetracyclines.
Exactly. And then at the other end, in older adults, we have to be really careful about liver and kidney function. As function declines, the body clears drugs much more slowly.
Leading to potential toxicity if you don't adjust the dose.
Correct. Accumulation is a real risk. We need baseline function tests and ongoing monitoring.
And then there are some really interesting genetic factors, too.
Yes, like G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. It affects red blood cells, makes them fragile. Giving certain drugs, especially sulfonamides, to someone with G6PD deficiency can trigger hemolysis, a massive destruction of red blood cells.
Wow, so you need to know that history.
You absolutely do. Another one is slow acetylation. This is a genetic trait affecting how quickly someone metabolizes certain drugs. If someone is a slow acetylator, standard doses can build up to toxic levels. These aren't just trivia, they're crucial safety checks before starting therapy.
Okay, great foundation. Let's finally jump into the specific drug classes. First up, sulfonamides. The common one is that combo product, SMX-TMP, right?
That's the main one we see used, yeah. Sulfamethoxazole combined with trimethoprim, often called Bactrim or Septra.
What's their mechanism? How do they work?
They're typically bacteriostatic, and they work in a really clever way. They're anti-metabolites, meaning they interfere with the bacteria's metabolism. Specifically, they block the synthesis of folic acid. Bacteria need to make their own folic acid to build DNA and RNA. Sulfonamides look similar to a key ingredient the bacteria need, PABA.
Para-imidobenzoic acid.
Right. They compete with PABA, get taken up instead, and basically gum up the works for folic acid production.
And human cells are okay
Because we don't make our own folic acid, we get it from our diet, so it selectively targets the bacteria.
Clever. And where do they tend to shine clinically? Where do they concentrate?
They get highly concentrated in the kidneys as they're excreted. That makes them a go-to choice for urinary tract infections, UTIs.
Makes sense. Any other key uses?
Yes, they're really important for treating and preventing a specific type of pneumonia caused by Pneumocystis jirovecii, often seen in patients with HIV. And they're also frequently used for community-acquired MRSA skin infections.
Okay, now critical nursing points. Safety alerts for sulfonamides.
Two big ones stand out. First, the potential for allergic reactions. The sulfa allergy is pretty common and can be serious. Anaphylaxis.
It can happen, yes. Rashes are more common. Tied into this is photosensitivity. Patients can get really severe sunburns.
So patient teaching is key here.
Absolutely. Strict sun avoidance, protective clothing, high SPF sunscreen, non-negotiable. The second big thing is the risk of crystalluria. The drug can form crystals in the urine, potentially damaging the kidneys.
How do we prevent?
Fluids. You need to push fluids, encourage intake of 2,000 to 3,000 milliliters every 24 hours to keep the urine dilute and flowing.
Got it. Any major interactions to watch for?
Definitely. They can significantly increase the effects of warfarin, raising the bleeding risk. They can also boost the effects of sulfonylurea drugs used for diabetes, potentially causing hypoglycemia. Always check the medication list.
Okay, sulfonamides covered. Let's move to the giants, the beta-lactam antibiotics. Huge group, right? It includes penicillins, cephalosporins.
Carbapenems and monobactams, yep. They're probably the most widely used class overall.
And they all share a core structure and mechanism. That's right. They all have that characteristic beta-lactam ring in their chemical structure. And they are all generally bactericidal. They work by messing up the construction of the bacterial cell wall.
How so?
They inhibit enzymes that are crucial for building and repairing the peptidoglycan layer. Without a strong wall, the bacterial cell basically can't hold itself together, especially in the human body where osmotic pressure is different and it leases or ruptures.
Powerful stuff. But bacteria are smart. They fought back, right? With beta-lactamase.
They did indeed. Many bacteria evolved to produce enzymes called beta-lactamases, sometimes called penicillinases. These enzymes specifically target and break the beta-lactam ring of the antibiotic.
Like chemical scissors snipping the drug's active part?
Exactly. It renders the antibiotic useless. So our counter strategy was to develop beta-lactamase inhibitors.
What do they do?
These are drugs like clavulanic acid, tazobactam, sulbactam. They don't have much antibiotic activity themselves, but they bind to and inhibit the beta-lactamase enzymes produced by the bacteria.
Protecting the actual antibiotic.
Precisely. You pair the inhibitor with the beta-lactam antibiotic. That's why you see combination drugs like amoxicillin clavulanate augmentin or piperacillin tazobactam or ampicillin sulbactam onesin. They overcome that resistance mechanism.
Very clever. Okay, let's break down the beta-lactam, starting with the original penicillins.
Yeah.
Still workhorses, yeah.
Absolutely. Drugs like penicillin G, penicillin V, amoxicillin, ampicillin, they're great primarily for many gram-positive bacteria. Think strep, some staph infections.
But some have broader reach.
Yes, the extended spectrum penicillins like piperacillin, especially when combined with tazobactam and zucin, have excellent activity against many gram-negative bacteria and even anaerobic organisms. They cover a lot more ground.
What's the number one issue with penicillins, the main reason you wouldn't use them?
Allergy. Penicillin allergy is the most commonly reported drug allergy. Reactions can range from a mild rash to life-threatening anaphylaxis.
And this leads to the concern about using other beta-lactams, like cephalosporins, right? Cross-reactivity.
It does. Historically, there was a concern about significant cross-reactivity between penicillins and cephalosporins. The thinking was, if you're allergic to one, you might react to the other.
Is that still the case?
The actual risk is now understood to be much lower than previously thought, probably less than 1% for most patients, especially with the newer cephalosporins. However, the standard advice is still cautious. If a patient had a severe immediate penicillin reaction like hives, throat swelling, anaphylaxis, you should generally avoid cephalosporins just to be safe.
Okay, better safe than sorry with severe reactions.
Yeah.
Any critical administration points for penicillins?
Two key ones. First, for oral penicillins like penicillin V or amoxicillin, instruct patients to take them with a full glass of water, not with acidic fruit juices like orange or grapefruit juice.
Oh, not juice.
The acid can potentially degrade the antibiotic before it gets fully absorbed, reducing its effectiveness. Water is best.
And the second point?
This one is a major safety alert. The thick, milky, intramuscular IM formulation of penicillin G, often called procaine or benzathine penicillin, it must never, ever be given intravenously, IV.
Oh, why not? What happens?
It's incredibly thick, like a paste. Giving it IV can cause a potentially fatal pulmonary embolus or other severe cardiopulmonary complications. Huge red flag. IM only for those specific formulations.
Got it. Extremely important point. Okay, next in the beta-lactam family, cephalosporins. Kind of like penicillin's cousins, right?
Structurally similar, yeah. Same core mechanism, bactericidal, inhibiting cell wall synthesis. They're grouped into 5 generations.
What's the significance of the generations?
It generally reflects their spectrum of activity. As you go from the first generation up to the 4th and 5th, you typically see increasing activity against gram-negative bacteria.
So later generations are better for gram-negatives.
Generally, yes. They often penetrate the outer membrane of gram-negatives better or are more resistant to certain beta-lactamases. Conversely, the first-generation drugs like cefazolin, Ncef, or cephalexin, Ceflex, tend to have the strongest activity against gram-positive bacteria.
So you choose based on what you're targeting.
Exactly. First gen for maybe a skin infection likely caused by staph or strep. Later gens for more complex infections potentially involving gram-negatives.
And there's a standout in the newest generation.
Yes, the 5th generation. The key drug here is ceftaroline, Teflaro. Its major claim to fame is that it's the only cephalosporin currently available that has reliable activity against MRSA, methicillin-resistant Staphylococcus aureus.
Wow, that's a huge deal for treating serious MRSA infections.
It really is. It filled a significant gap, especially for things like complicated skin and soft tissue infections or community-acquired pneumonia caused by MRSA.
Now, there's a specific and pretty severe warning associated with some cephalosporins and lifestyle choices.
Ah, yes, the disulfiram-like reaction. Certain cephalosporins, most notably cefotatin, can cause this nasty reaction if the patient consumes alcohol.
Even small amounts. like in mouthwash.
Yes, even alcohol in things like mouthwash, some cough syrups, or even some IV medications preserved in alcohol. Patients must be strictly warned to avoid all forms of alcohol during treatment and for up to 72 hours after the last dose.
What happens if they don't?
They can experience severe flushing, throbbing headache, nausea, intense vomiting, chest pain, palpitations, shortness of breath, sweating, and even dangerous drops in blood pressure. It's miserable and potentially dangerous. Strong patient education is vital.
Absolutely. Okay, let's quickly touch on the last two beta-lactam groups, carbapenems and monobactams. Carbapenems, first, they sound heavy-duty.
They are drugs like imipenem-cilastatin, Primaxin, meropenem, Merim, ertapenem, Invance. These have the broadest spectrum of activity of pretty much all antibiotics.
So used for the really tough infections.
Exactly. They're typically reserved for complicated, severe infections, often in hospitalized patients, especially when you suspect multidrug-resistant organisms. They cover gram-positives, gram-negatives, and anaerobes.
Is there a major risk associated with them?
Yes, the most significant concern is the potential for drug-induced seizure activity. The risk seems highest with imipenem-cilastatin, particularly at high doses or in patients who already have kidney problems or a history of seizures.
How do we mitigate that risk?
Careful dosing based on renal function is key, and these drugs must be infused slowly, typically over 60 minutes, not given as a rapid IV push. Close monitoring is essential.
Okay, and briefly, the monobactams, what's their niche?
The main one here is aztreonam. Azactam, its spectrum is quite different. It primarily targets aerobic gram-negative bacteria like Pseudomonas, E. coli, Klebsiella. It has virtually no gram-positive or anaerobic activity.
So why use it? What's its unique value?
Its key advantage is structural. While it is a beta-lactam, its structure is different enough that there's very little allergic cross-reactivity with penicillins and cephalosporins.
Ah, so it's a good choice for a patient with a serious penicillin allergy who needs gram-negative coverage.
Exactly. That's its primary role. Safe option for gram-negative infections in patients with documented IgE-mediated penicillin allergies.
Great. Okay, we've powered through the cell wall inhibitors. Now let's switch gears completely to drugs that mess with protein synthesis. First up, macrolides. Examples.
Classic examples are erythromycin, azithromycin, Zithromax, Z-Pak, and clarithromycin, Viaxin.
And how do they work? Are they killing the bacteria?
They are generally considered bacteriostatic. They work by binding to the bacterial ribosome, specifically the 50S subunit.
The ribosome is the cell's protein factory, right?
Exactly. By binding there, macrolides essentially block the factory's assembly line, preventing the bacteria from making the proteins they need to grow and function.
What kinds of infections do we use them for?
They're commonly used for respiratory tract infections like community-acquired pneumonia, bronchitis, strep throat, if penicillin allergic. Also used for some skin infections and certain STIs like chlamydia and syphilis.
And erythromycin has that weird side use, right? Nothing to do with infection.
That's right. Erythromycin is notorious for causing GI upset, nausea, vomiting, diarrhea. But that side effect, stimulating GI motility, has actually been harnessed. It's sometimes used off-label to treat conditions like diabetic gastroparesis, where the stomach empties too slowly.
Interesting. Now, the big red flag with macrolides seems to be interactions, particularly with the liver.
This is probably the most critical safety point for macrolides, especially erythromycin and clarithromycin. Azithromycin is less problematic here. They are potent inhibitors of the cytochrome P450 enzyme system in the liver.
Okay, what does that mean clinically?
It means they slow down the metabolism of other drugs that rely on those same enzymes. So if a patient is taking a macrolide plus another drug metabolized by P450, the level of that other drug can rise significantly, potentially reaching toxic levels.
Which drugs are we talking about?
Common examples include warfarin, risk of bleeding, certain statins, risk of muscle damage, theophylline, risk of toxicity, cyclosporine, and others. You absolutely must do a thorough medication reconciliation before starting macrolide.
Huge potential for dangerous interactions. Anything else?
Yes, another important point. Macrolides can also reduce the effectiveness of oral contraceptives. So counseling about using a backup method of birth control during and shortly after treatment is essential.
Good to know. Okay, our final class for today. Tetracyclines, like doxycycline, minocycline.
And tigecycline, which is a newer related drug. Yes.
How do they work? Also protein synthesis.
Yes. They are also bacteriostatic protein synthesis inhibitors. But unlike macrolides that hit the 50S subunit, tetracyclines bind to the 30S ribosomal subunit, again messing up protein production.
What are their main uses?
They have a pretty unique spectrum. good for treating acne, certain STIs like chlamydia, and they're key drugs for tick-borne illnesses like Lyme disease and Rocky Mountain spotted fever. Also used for some respiratory infections and H. pylori infections.
Now, tetracyclines have some really significant contraindications related to their chemistry.
Absolutely critical ones. Tetracyclines have a strong affinity for calcium. They chelate it, meaning they bind to it.
And that causes problems where?
Primarily in developing bones and teeth. Because they bind calcium, they get incorporated into these structures. This means they are strictly contraindicated in children younger than 8 years old and in pregnant or breastfeeding women.
Why? What happens?
In young children, it can cause permanent, noticeable discoloration of the teeth, yellow, gray, or brown staining. It can also potentially affect skeletal development. Not worth the risk if other options exist.
That's a major warning. Does this calcium binding thing affect how you take the medicine?
Yes, significantly.
Hmm.
This chelation property means tetracyclines should not be taken at the same time as calcium-containing foods or supplements.
Like milk, yogurt, cheese.
Exactly. Also, antacids, which often contain calcium, magnesium, or aluminum, iron supplements, and even things like magnesium-containing laxatives. They all bind the tetracycline in the gut and prevent its absorption.
So how do patients manage that?
They need careful teaching. They must separate the tetracycline dose from any of these interacting substances. The usual advice is to take the tetracycline either 2 hours before or 3 hours after consuming dairy, antacids, iron, etc. Timing is crucial for effectiveness.
Wow, that's a big teaching point. Any other major side effects?
Like the sulfonamides, they also cause significant photosensitivity. Again, strict sun protection measures are needed. They can also cause GI upset.
Okay, we've covered a ton of detail on these 5 classes. Let's try to bring it all together now, thinking about the nursing process. What are the key implementation actions and patient teaching points that cut across these different antibiotics?
I think the absolute #1 point stressed over and over is adherence. Patients must take the entire prescribed course, even if they start feeling better after a few days. Stopping early breeds resistance.
And taking it correctly.
Yes. Doses need to be spaced evenly around the clock, like every 6 hours or every 8 hours, whatever is prescribed to maintain consistent drug levels in the body, not just, 3 times a day whenever they remember.
What about watching for reactions?
Definitely monitor for allergic reactions, obviously right away, but also be aware of delayed hypersensitivity reactions, which can sometimes pop up even 24 to 72 hours later. And always, always clarify and document the specific type of reaction someone reports to an antibiotic. Was it just mild nausea, or was it hives and difficulty breathing? Huge difference for future prescribing.
Good point. What about preventing those superinfections we talked about earlier?
We should encourage patients to consider using probiotics, things like yogurt with live cultures, kefir, buttermilk, or even probiotic supplements, especially during and after the antibiotic course. It can help maintain or restore the healthy gut flora.
And the contraceptive issue.
Yes, reiterate the potential for reduced efficacy of oral contraceptives, especially with macrolides and some broad-spectrum penicillins or tetracyclines. Advise using a backup method of contraception during treatment and usually for about a week after finishing.
Excellent summary of key actions. Finally, how do we know if the treatment actually worked? How do we evaluate the therapeutic effect?
Evaluation involves looking at several things. Subjectively, the patient should report feeling better, decreased fever, less pain, improved energy levels, better appetite. Objectively, we look for vital signs returning to normal, resolution of physical signs of infection like redness or swelling,
And lab tests.
and crucially, lab results. We look for improvement or normalization of the white blood cell count, and ideally, follow-up culture should come back negative, confirming the infection has cleared.
Perfect. So to just quickly recap the absolute core mechanisms we hit today.
We looked at drugs that destroy the cell wall that hold beta-lactam family.
Mhm.
Penicillins, cephalosporins, carbapenems, monobactams.
Then drugs that inhibit protein synthesis.
Right, the macrolides hitting the 50S ribosome and the tetracyclines hitting the 30S ribosome.
And finally, the antimetabolites.
The sulfonamides messing with bacterial folic acid production. Understanding those basic mechanisms really helps unlock why they work and what side effects to expect.
Absolutely. It provides a great framework. So here's a final thought for you, our listeners, to mull over. Given this ever-growing challenge of drug resistance we discussed and the complexity of these drugs, how do you think ongoing antimicrobial stewardship efforts, really focusing on using these precious resources appropriately, with the right drug, right dose, right duration, how will that shape the discovery and use of the next generation of antibiotics? Something to think about as you apply all this knowledge.